Thank you. So we are going to go to the next step. This is a high-level thing because we've already discussed quite a bit about research methodology even in the preceding lecture. And these are just thoughts because we are going to think about doing our own study and what we should think in clinic or wherever else. So now that you've registered for this research methodology workshop, you're sort of stuck in a problem-solving cycle. Now you're in. So Dr. Lobo has been talking about the problem, the first step, that is understanding and how we define it, and deciding how to answer it. What we will talk about, both I and Smriti, is to plan the actual study. That is what is essentially research methodology. How to measure what we are measuring, what is the kind of study design that we are taking, how we are recording and how we are collecting are more specific things that we won't be talking about. And then, of course, the cycle goes on to do things with the data that we collect. We clean it, we manage the data, all important things that we are not really talking about, analysis, and then finally come to a conclusion. These conclusions will probably give you new ideas to go back to the problem. So this is the kind of research cycle that we hope you all go into with a problem. So the main thing that I would say is, if you're doing research, have a love for data. What is data? Like Dr. Hase just said, it is nothing but a systematic record of any quantity, of a particular quantity, of any quantity, just a collection of facts, that's it. And this is to differentiate it from just an experience. We tend to think that if I have experienced, it must be true, right? If yesterday we saw that example of very eminent scientists saying, I've taken vitamin C at very high doses, or if somebody in the patient population comes and tells you that my child had a sandwich and now it's giving him a headache. It's an experience. We don't know if it is true or not. It is true for that person. That did happen, but that does not give you too much information. Or you have these things, right? You have both doctors and patients saying this. My patient improved the day I prescribed remdesivir in COVID. Didn't he improve because of remdesivir? We don't know, but that is implied. So we think causally, and we think that experiences are how we get things across. And we want to try and suppress this internal need by a systematic record of a particular quantity. Right, so there's this very interesting book called Dear Data. It's very aesthetic, very pleasurable to see. It's a tale of two friends. One lives in New York and one lives in London, and they are both data artists. That's a new field these days. So what they decided to tell each other is that they would send each other one postcard per week. Drawing something on the back of the postcard, that's it. Right, so they're just drawing an experience on the back of the postcard for that one particular week. For example, this 1 week, every time this lady looked at the clock, she put it down. And she put that into various kinds. So if she looked at the clock on purpose to know what time it was, she drew a clear circle. If she just glanced at the clock, she drew a solid point. Because she was bored, she drew one bar. Because she heard somebody saying the time allowed, she put in a triangle. So basically, she's converted a very simple experience, just looking at the clock, it's nothing even fancy, to a collection of records with categorization and labeling. And then look how pretty her postcard looked. So from 7 a.m. to 12 midnight, from Monday to Saturday, she's put down all times that she's looked at the clock. And you can get so much information about this, right? About her day, what she's doing, when she's bored. At 7 p.m. every day she's bored. She just wants to go home. At 12 p.m. every day she's hungry every day. So you get a lot of information out of collecting and recording even very, very simple experiences. And that's essentially what we are willing to, or we want to do, record experiences. That's essentially what we are doing. And it's essentially what we are doing in studies as well. What are we doing? There's not much difference between her simple postcard looking at the clock and these records of what happened to children and adults hospitalized with COVID-19. Both of them, that lady sitting in New York and the people in 7 or 8 centers across Africa, they've recorded things. Rather than seeing one patient being happy that they did well or being unhappy that they didn't do well, they've recorded things, put it in a particular format and put it out. And basically it gives you the power to go past one experience and to build a corpus of information that the world can use. This is what we are doing with descriptive studies. We are observing phenomena. The phenomenon can be simple, the phenomenon can be complex. There is hardly any hierarchy. Some will be relevant to you, somebody will be relevant to somebody else, but that's essentially what we are doing. We are observing the world. And that's the first goal of studies that we are doing, is we are just describing things. And most of science, maybe even until the 1970s, most epoch-making science has been observing things. Darwin observed that some finches have different shapes of beaks. It's an observation. He's done nothing. He had no hypothesis. Watson and Crick observed that the diffraction patterns of radiographs from these molecules look a certain way. So most epoch-making studies are descriptive. And we have many studies going on like this. The census, outcomes of patients with lupus nephritis, they are descriptive studies and still important. The other goal of studies is what appeals to our causal mind. So we find that we think causally, like that lady who thought that her kid got a headache because of a sandwich. We think causally. If I get an upset stomach, I think it's because I've eaten something the earlier day. It has to be because of something. So here we are thinking, is this true or not? And these are inferential studies. So here we are trying and answering a question. The descriptive studies do not have a hypothesis. Inferential studies do have a hypothesis. And the hypothesis is something that we have probably observed. And this has been converted to a question. So we think, have unemployment rate, we feel that COVID must have been terrible to people. Have unemployment rates gone up? Are ORS solutions okay to use if IV fluids are not available? These are some important questions that people have solved because they thought of a hypothesis. So we've been studying these kinds of study designs. I won't be going too much into detail, but essentially within an observation, some of them are descriptive, but some you can use hypothesis testing. Experimental studies, of course, is when you're manipulating something, and meta-analysis is when you're combining all of these to form a bigger level of, or a bigger collection of evidence. Right. So what is an inferential methodology? Many kids, MBBS kids, tell me, if I ask them, why do you want to do research? They have this thing where they want to act like a detective. They say that we want to be like Sherlock Holmes and answer questions. So are we acting like detectives? Are we like Sherlock Holmes? I think we are one step better. Because what Sherlock Holmes does is a process called deduction. Deduction is taking a general idea or logic and bringing out particular conclusions from it. So for example, if he sees that someone's trouser is splattered with mud, and if you ride in the left side of a carriage, you are likely to get mud splattered there. He's taking that general idea and telling them that you came in a carriage and you sat on the left. So he's deducing something, right? What we are doing is not this. what we are doing is called induction, which is probably one step higher because we have the conclusions. My 20% of patients with lupus nephritis developed ESRD or whatever else. This is my conclusion, and then we are trying to bring that into a general idea, not the other way around. So we are not, the above one we often use in the clinic in diagnosis and treatment. What we are doing with research is inductive reasoning. So that I have observed certain things, these are my conclusions, and I want to convert them into general ideas, right? So this is what Dr. Lobo also talked about. This is the same kind of flow chart where from the data available to you, you take one particular sample, and the problems here are the problems of measurement. So when you are taking a sample, one wants to think about, is this sample reliable? And what reliability means is that if I do it, or if Smriti does it, or if Dr. Lobo does it, if I have been precise enough, will we take the same kind of sample again and again? So this inter-rate or variability of if I do a sample now and if I do a sample 20 years later, will it be the same kind of sample? If there's a huge difference, it's not a reliable sampling method, and then you might have problems in interpreting the results from that kind of sample. Is the sample valid? So are we sampling what we want to measure? Is the other question that we want to answer. From the sample, we make conclusions about the study population, and from the study population, then we make conclusions about the target population. So this is what I said and what Dr. Lobo has described really well with what is inductive reasoning. Right. So, like I said, doing research is asking questions, especially the hypothesis, especially inferential research. No question is important or not important. No question is right or wrong. But it's good to have a look at what kind of questions we are answering. Right? Do people get nervous while speaking to others in a group? Maybe, like looking at me, you're likely to say yes. Does smoking cause cancer? Will this glomerulonephritis patient's renal function improve with immunosuppressant? So if you think about it, most questions that we ask are causal. What we are trying to look is, will something lead to something? Is one phenomenon giving rise to another phenomenon? Right? So the first question that one would like to ask yourself is the question scientific? So the science philosopher Karl Popper has a definition, is that a question is scientific when, or a statement is scientific when it can be confirmed with empirical evidence. If you gather evidence and you can confirm that statement, so then that is a scientific statement, right? So let's see by a show of hands. What do you think about these statements? Cold weather increases rates of suicide. Do you think this is scientific or non-scientific? Scientific? Raise your hands. Only Siddharth thinks it's scientific. It is scientific because you can prove this, right? I mean, you can measure the rates of suicide in cold weather. You can measure rates of suicide in warm weather. It is definitely scientific. Eating sour foods increases rheumatoid arthritis pain, swelling. Is it scientific? Yes. Yeah, I mean, it sounds wishy-washy, but it is scientific from Popper's this thing, because you can refute it with empirical evidence. It's, I mean, it doesn't happen, but you can say that, no, this doesn't happen. Dogs are better than cats. I mean, it is intuitive that it is true, but some people might disagree. But is it scientific? No. Why? Exactly. More than this, you don't know what you're measuring. So what is better? So if I want to convert it to a scientific question, I could do something like this. Dogs are better than cats at tracking down smells. So then that becomes a scientific, because you can measure how a dog tracks down smells or whatever else. How about this one? A very classic question, a classic statement. Humans and apes are descended from a common ancestor. This was the exact statement in Darwin's original. Is it scientific? So now maybe it is scientific with the methods available to us today. But at the time it was a non-scientific statement. So when Popper wrote his discourse, it was non-scientific. So I'm glad Darwin didn't listen to this lecture. Otherwise, we would have been thinking about creationism. And a new drug A increases the risk of renal impairment? Yeah, that's straightforward. That's a scientific question. So that is the first thing that you would like to think of when you're planning a research study is your questions scientific, because it's really difficult to think about how to prove dogs are better than cats. So you can start thinking about this the next time people talk to you also. My political party is the best. This is not a scientific question or a statement. You can tell them that you can ask them the best at what. Only then can we say if it is true or not. So the next question that you would like to think is, what is the variable? So when, like I said, we are studying change. If something is giving rise to something, then we are studying change in the second something, right? If A is giving rise to B, then we are studying change in B. But we are also studying change in A. So both of these, A and B, are called variables because they change. And because B is influenced by A, that is called dependent. And A is called independent, right? So it's good to think about what, in your question or in your statement, what the independent and dependent variable is. So for example, drug A increases the risk of renal impairment. What would be the dependent variable? Kidney function. Yeah, exactly. And the independent variable would be drug A. It is also changing. You can change it. You can give higher doses. You can give lower doses. So independent variable is drug A and dependent is kidney function. Frustration causes aggression. What would be the dependent variable? Yes. So aggressive behavior is dependent. You are trying to ask if frustration is the independent variable that is producing aggressive behavior. Is it worth spending 3 hours on a Sunday morning on a research conference? What is the dependent variable? Correct. So I've called it long-term utility. Is it worth thing? And the independent variable is how I'm spending my time on a Sunday. And what fraction of a lupus patient received mycophenolate? No, this is not an inferential question. This is a descriptive question. So here you would not have independent and dependent variables. So this is the kind of question that we saw, like COVID or like that lady looking at clocks. Right. So the next thing that you would like to ask is, how will I measure my dependent variable? Because that has to be valid. That has to be reliable, like we said. So drug A increases the risk of renal impairment. How would you measure the dependent variable? Yeah, exactly. I mean, I've written creatinine levels, but there might be much better ways. So you want to think about how you're measuring the dependent variable. Frustration causes aggression. Okay, but how would you measure it? Yeah, so yeah, maybe like a questionnaire. How frustrated are you? How aggressive are your behavior, or video camera data? If you're going around slapping people, that thing. Is it worth spending time on a Saturday morning here, Sunday morning here? How would you measure the dependent variable?
Number of publications after 5 years.
Yes. Great. I've exactly written the same thing. Fabulous. That's amazing. So maybe a satisfaction questionnaire. So when you look at measuring the dependent variable, we have to look at reliability. So if 3 people do it, will it be the same? If I take video camera data of aggressive behavior, everyone looking at it, and if you've predefined what aggressive behavior is, everyone looking at it is going to say that yes, this is aggressive behavior. So it has to be reliable. It has to be valid. Validity means that you are measuring the construct you want to measure. So if I want to measure aggression and I have video camera data and all I see is people eating food and I see the amount of movement here and there, We are not measuring aggression per se. So that is the other thing. And the third thing is practicality. Obviously, study for 5 years, number of research papers in 5 years is not going to be a very easy study to do, but a satisfaction questionnaire I can give at the end of the afternoon. So practicality comes into how you measure the dependent variable. Then you think about what kind of study design you want to do. If it's an observational or a correlational study design, or is it an experimental study design, right? There are many similarities in both of these. Both are empirical, that is any evidence that comes from measurement or that comes from observation that can be replicated. Both are replicable, both are objective. So you want to think of the similarity, these two. The only difference between these two is one, that is manipulation. One variable is being manipulated, the independent variable is being manipulated in the experimental design and not in the observational design. That's really the only difference, right? And why is it so important? Why is experimental design have such a high pedestal in scientific life? Again, we come back to the same thing, that we are trying to assess what we want to believe in, that is something causing something, right? If a lady said that this drug gave my child a headache, is it causal? How do you know that the drug gave your child a headache? For example, if the drug gave her child a headache 20 times, then you more and more think that maybe yes, it is possible that it is the drug which is giving a child a headache. So if you had taken records from a hospital or from insurance claims and searched out headache and searched out whatever drug this is and found that both of them correlated, maybe it was a drug for headache, right? So everyone with a headache took the drug. So they would be correlated in that kind of data. But the causation, the temporal causation is opposite. So the time when it occurs, one after the other, is important. This is one way of thinking about causality, that temporal association, the number of this thing. So the second thing is called dose effect. So if you have smaller doses, you get a smaller headache. You have bigger doses, you get a bigger headache. All of these things sort of push your intuition more and more to think about causality. A better thing would have to be to have a control. If drug A gives the kid headache and drug B he's playing about, and this happens again and again and again, then you have a control when both times he's taking the drugs for the same thing, that you at least know that maybe it is not because of anything else that is happening, but actually the drug. And to further that, push that intuition, if you bring in randomization, then you're, like we've talked, we've controlled for all these other possible factors. So that is basically what we are trying to do, is push towards getting better and better at answering the causal question. So the next question that we ask in our thing is, can I manipulate the independent variable? So can I do an experiment here? So drug A increases the risk of renal impairment. Can we manipulate the independent variable? Yes. I mean, you can either give it or not give it. So that's a 0 or 1, or you can manipulate the dose, or you manipulate how long you're giving it for. Frustration causes aggression. Slightly difficult experimentally, right? I mean, you'll have to make some people frustrated or make some people less frustrated. Slightly difficult. Worth spending my time? Maybe you can have a control group here. Like half the people go to a research workshop, half the people go to Alibag, and then see which one does. So you can manipulate it some ways. But you come across many situations in which experimentation is unethical or impractical. So you can try and answer causal questions even with observational research with what are called quasi-experimental techniques. So you mimic randomization. There are some fabulous techniques now, Mendelian randomization, some other things, which I won't be talking about. But essentially what you're trying to do here is mimicking what you would have done if it was an experiment. So for example, even if it's single test, pre and post test group, and you measure and then you treat and then you measure, and the treatment can be a disease. We are just calling it a treatment. The treatment can be something completely different. For example, a COVID infection. So if you have measurements from before and then all of them after a COVID infection you measure again and find that they have muscle pain and all of that, then that is essentially how you've thought about long COVID. We haven't given half people COVID and half people without COVID and say that this is producing it. Or you have something called interrupted time series where you take measurements and then suddenly there's some event and then you keep taking measurements. So you can compare what happened before the treatment to what happened after the treatment. So this is important in natural phenomena. So there's this group of very influential studies called the Dutch winter hunger studies. So there was a huge famine in Holland. And before that, the size of babies, and after that the size of babies, and then long-term metabolic complications were compared and found that early life malnutrition really produces long-term effects. So these kinds of techniques do help in causal questions, and they are very practical when obviously many times experimentation is not possible. Okay, so these are the steps on how you think about a research question and what methodology. I'm going to ask Smriti to take over. She's going to talk a little bit about qualitative research, and then we'll open it out for the exercises. Yeah.
Good morning. Far, far away from the land of quantitative research is an island which I've come to talk about. So if, like me, you did not take maths or did not enjoy maths in school, don't enjoy data crunching, but still want a number of titles on your CV, then I may have the answer for you. So we haven't touched too much upon qualitative research up until now, but the basics are here is that in qualitative research, the aim is to examine how and why certain experiences, certain behaviors or decisions occur, in contrast to what we may measure in what Sanat and everyone else have been speaking about, which is the effectiveness of the intervention. So in effect, we are measuring the experience, the phenomenon, or the behaviors around this. So qualitative research can be used to supplement quantitative data. It can also be used as an initial hypothesis generating process, which can then later on be explored by a quantitative study. And sometimes I have one slide on this on how it can go hand in hand with quantitative to become a mixed methodology study. Now, what's important in qualitative research is that you are using theory as a basis or as a lens to view whatever it is that you are studying. So there are different research designs that where different theories are underlined, and that is the lens that you are using to examine this, because a lot of this is experience driven. We usually either generate theories out of it or take pre-existing theories and try to fit it with the data that we have. One interesting thing is that you may also find that the research question is changing during the study. It's not that the question will change radically, but you are using the data or the information that you are getting at the study to decide how many more interviews to conduct. Do you need to change your original research question based on the information you have received? there is a trend now in research about more contextualization, more understanding of real world problems, trying to place diseases in the context, in the culture, in the groups and subgroups that people are in. So just the idea that there is no one real world, I think there are a lot of philosophical there is structuralism and post-structuralism around this. So the idea that there is no one single world, there are narratives which are different narratives based on the people who are experiencing it. And so that's what qualitative research does. It tries to provide an in-depth understanding of the context in which any problem is situated. So the how and why rather than the when and how, when and what. So experiences, attitudes, and behaviors. So this was a study that was recently published, I think last year, which talks about the cultural influences on whether patients whether patients with CKD do physical activities or not, or what their beliefs are around exercise. And you can get the knowledge that you've generated with this data can then be used to actually create real-time interventions or interventions which can then maybe actually change these beliefs. It also makes clinical practice and evidence-based medicine more efficient, more effective, more humane, more centered in human behaviors and human understanding. So trying to understand, say, what are the barriers to reducing sodium intake in patients with CKD? What are some of the support strategies that can be used? And then you actually have basically this is you're going to the well to draw water from it. You are going back to the patient and trying to understand why is it that they aren't able to reduce their sodium intake. And then you use this data to actually then create interventions that will reduce the sodium intake. So how do we collect data in qualitative research? It can be from impartial or as impartial as possible observation. You can conduct interviews, structured, semi-structured. You can have focus groups where groups of people who have some things in common will come together and discuss particular number of questions. You can have surveys with free text where you will invite people to write down or talk about their thoughts and then analyze it. And you can use secondary data which is already present out there. And then coming to the study designs. So these are some of the different study designs which are used. This is the theory that is the lens that guides your qualitative research. So these are some of the most common study designs used. There are actually quite a few more. So ethnography is basically the basis is in anthropology and understanding the culture of a group of people. And so you understand the worldview of the group under study. So here you will tend to take people of a similar culture. So the previous one which I had shown about the BMJ study would be, say this one would be something like that. Like that may be the lens that you would then use. So that is ethnography. Phenomenology is observing a phenomenon but taking the experience from the person actually experiencing the phenomenon and understanding why they behaved as a result of that. Grounded theory is actually kind of like the opposite. So in phenomenon, you are seeing the experience and then making a theory out of it, while in grounded theory, you are, grounded theory is the opposite of phenomenology, in which you are observing a study population and actually generating the theory through the observation. So here, this is also another of the common study designs that is used. And then we have narrative research. So there are narrative studies, like there is narrative analysis. Narrative research is also very individualized or more towards the person that is experiencing the phenomenon. So focuses on the narrative or the story of the phenomenon or the personal experience. Narrative research will usually, you will find that the data that is generated is very descriptive and a lot of ideas can actually come from the narrative. And this is how you can then generate hypothesis and go forward. This is an example of a mixed method study where you can see that they actually used 3 different questions for each of the methodology. Now, you might think that actually mixed method study is simpler because you are trying to you will get to do 2 different things together, but in effect it becomes difficult because you have to bring the same academic rigor of a quantitative study and a qualitative study. So in fact the work that you will end up doing is going to be double. And a good mixed method study actually links the quantitative and the qualitative question together. So like in this one, symptom experience in a patient with end-stage renal disease, it is important to first understand the symptom burden. And so knowing how much symptom or what is the symptom burden that a patient is facing, and then how they experience this symptom burden, and then trying to correlate the two. So here you see that there are actually 3 different research questions that this study is aiming to teach. So this is actually a very ambitious study. So like we have metrics for evaluating how good a quantitative research is, you want to look at the credibility, the transferability, the dependability, the external internal validity, the reliability of the study. There are similar metrics for how to determine the whether a qualitative research is good or not. So credibility is by having multiple points of data collection. So if you are able to use multiple methodologies, like maybe having focus groups as well as surveys together. So this will help ensure more accurate results. And peer examination, which is when more than one study author looks at the data and then comes to conclusion. Qualitative transferability is when there is a detailed description of the process. So like everything else, even in qualitative study, it comes back to methodology where if you are able to in detail describe the process, then someone else can also replicate it. And then dependability and conformability is by an audit trail. So I think that's about what I wanted to discuss in like just a short introduction to qualitative research. I'm going to hand it back to Lobo sir if you want to discuss the questions again, or
People are there who are delegates for the workshop. How many? One.
We can all participate.
Everyone.
Yes.
So then maybe split into 2 groups. So the idea was that what Sanat talked about and Dr. Smriti talked and what I talked, we'll now give you we'll give each of the groups an idea. You use that idea to create a research question and a study design. So some people from this side can move to this side. And then after that, one spokesperson from each group can come up and give us the picotes of that. So this group here, my idea is that the length of doctor's prescriptions is proportional to the number of MRs who visit. So let's hear how you would have a study. And the second one is here that National Board thinks that basic sciences lectures are very important. So let's have a study to see whether nephrology students perform, how nephrology students perform with basic sciences lectures. So those are just, I've thrown ideas. Maybe 15-20 minutes?
Yeah, 15 minutes.
We have 15 minutes.
Yeah.
So it'll be good to write down the steps of your
steps,
thought,
and
like
then
what your research question is, why you thought of
You
it.
can discuss, huh? You're not
Yeah.
supposed to do it individually.
Yeah, discuss
Group can get
within
together
yourselves.
and one
And yeah.
person come up as a spokesperson afterwards
Yeah.
and tell us what the study is.